Okay, I will be talking on finding the missing TB cases using digital X-ray with artificial intelligence. Our experience from KNCV TB Foundation Nigeria. I will use the opportunity to thank the USAID Nigeria for all the support to KNCV that had made most of our work in Nigeria possible, and the National TB and Leprosy Control Program for their support and collaboration. Can you go to the next slide? Yeah, I'll be giving some background information on TB epidemiology in Nigeria and who we are as KNCV Nigeria. I will present our pioneering work in the use of digital X-ray with AI, the wow truck, or which we've seen in some of those pictures before now, and effort at scaling up digital X-ray with AI for TB case finding using the portable digital X-ray, our relationship and partnership with Delft. And I'll talk more on a new innovation that we'll try to introduce, the awareness on Keke, discuss on our screening algorithm, share some of our results, and talk more on some of the innovations that is actually helping to drive this intervention. Very minimal challenges, and I will then conclude. The next. Now, Nigeria, as we all know, is the 6th highest burden for TB globally and the 1st in Africa, with a triple burden of both TB, MDR-TB, and TB-HIV. And the incidence from the last global report, 219 per 100,000 population, with low TB treatment coverage of 44%, as just reported in the recently released global TB report. Nigeria accounts for 8% of the gap in global TB notification. And it is known to everyone here that an undiagnosed TB patient is capable of infecting 10 to 15 persons every year. And weak health systems, suboptimal community to facility linkage makes TB case finding a challenging one in Nigeria and in most developing countries. The next. Now, this is our journey as KNCV. Most of us know KNCV The Hague, a journey in Nigeria starting as early as in 2004, when they started providing support with the United States Agency for International Development funding, starting with TB CTA, TB CAP, TB K1, and Challenge TB project. But in the course of Challenge TB project, there was actually a move for transition to a national entity. And this journey started as early as 2016 to 2020. And within that period, during the transition process, we were able to get grants through as a sub-grantee under SHOS Plus, the WAS project, of which the WA truck was a key component, and that was funded under United States Agency for International Development. But not until 2020 that we became KNCV Nigeria, a national entity. And I must commend USAID and all the partners and our team out there in the field. We've really come of age with increasing impact in the area of TB control. Our legacy project is the TB Long 1 and 2, all which we are funded by USAID to provide support, working with the national program across 14 states in Nigeria. And we're equally implementing the Global Fund PPM project in 5 states, and through the funding from USAID under GLOVAS project, we're equally implementing the COVID vaccination project in additional 7 states, and working with a consortium of partners in the accelerating control of HIV epidemics, cluster 6, funded by USAID. We are working with HAG in implementing an HIV program in 3 states in the country. And we equally, under KNCV Nigeria, introduced the digital adherence technology that was implemented in 8 states, and with very good lessons that could inform a national scale-up. Presently, we're probably working with National Program and System 1 on TB connectivity projects. And very recently, we got another grant for TIFA, is a TIFA project under JSI to implement 2 projects, the STORM and SOP. It will be happening in 2 of the high burden states in Nigeria, Akwa Ibom and Kano State. Next slide. Now, looking at our project map, KNCV Nigeria coming on board since 2020, we've made very great progress. And most of all these projects are spread across 20 states. And we all know Nigeria has 36 states and the Federal Capital Territory. And we've been able to impact across these 20 states since coming on board in 2020 as a national entity. The next slide. Now, we pioneered the chest X-ray with AI into the Nigeria TP space, the WOW truck. This truck actually were procured under the Challenge TB projects. That was in 2018, and integrates chest X-ray with artificial intelligence. And each has a two-modular gene expert machine. We call it the wellness on wheel truck, and is actually well known in Nigeria. We have the two of them, one serving the northern part of the country and another serving the southern part. It had actually been very, very key in our targeted TB case finding using hotspots, especially within the communities and hard to reach locations. The clients are screened using the chest X-ray with a CAD4 software that digitally profile patients that are presumptive, and based on score, which we actually learned over time, starting from the cutoff of 60, and I will stay talk on the digital X-ray, which will set the cutoff 50 and above. These actually help to profile presumptive, and on the spot, as you can see that the truck at the back, it has the diagnostic component housing the gene expert, and towards the front is where you have the X-ray. And those that are able to produce sputum, the presumptive on the spot, are actually tested with the gene expert machine. And during the COVID, using the card for COVID, this was actually integrated, and we implemented this in Kaduna State. But another thing worthy of noting is that the WOW truck is just beyond a diagnostic tool. It's actually a tool for high-level advocacy, of which we are happy with the results we've recorded in Nigeria, where some of these states are keen into the WOW project and even procuring for the state. A good one was in one of the states in the northern Nigeria, where the governor actually keyed in the WOW project and procured 5 of these WOW trucks. Another thing that once WOW truck moves into a location, it creates the WOW nature of it that even when the WOW truck has left the location, people actually are more sensitized about TB, and you could see increase the uptake in some of the facilities for TB services in these locations. The next slide. Now, scaling up the digital X-ray with AI for TB case finding. I must actually thank Delft. We as well, just coming up as the KNCV Nigeria towards ending of 2019, we got to know about the introduction of the Delft light, and we reached out to Delft and we had a negotiation for a pilot. And I'm happy to know that just that small beginning of a one Delft light in Nigeria had led to what we've been able to do. Not only KNCV, the national program, you could see Mohammed telling us that about 20 of these DLB are coming in country, and through the New Truths project, we've been able to, USAID, we've been able to procure 10 that have been shared between some of the implementing partners. And we actually glad to note that this pilot project actually opened the door for most of these things we are seeing. And our success with the pilots, which we'll be able to learn lessons from the WOW truck, and with the lone portable digital X-ray from Delft, we had a 6-month pilot, and actually the outcome had also been published. And we now keyed into the New Truths project with funding from USAID, and KNCV is presently implementing 7 additional DLB platforms. And this platform I use for active case finding in hotspot communities. I could see my colleague presented on what they do within the facility. But in Nigeria, the key gap in case finding actually within the communities. And we are already programming with the mobile X-ray and the WOW truck to help to bridge the gap in case finding within the communities. And the very, very good thing with the digital X-ray that it had come to show efficiency in TB case finding, as I will show in subsequent slides of our results, that the number needed to screen and number needed to test had actually reduced very, very significantly to a single digit. And you could know the cost savings in the use of gene expert, the cost savings even in mobilization to targeted communities. The next slide. Now, this is another new innovation. We've learned lessons from the WOW truck. The WOW truck is big, it's cost intensive. It goes with many number of staff, the driver, the gene expert team, the radiographers, and even the cost of maintenance. I must equally thank Delft. When we came up with this concept, we worked with Mohammed, and the Delft actually did the design. But looking at cost consideration and make keen into a local content, we're able to reach out a local car manufacturing company in Nigeria that designed what we call it is awareness on Keke. We call it the walk. The big one is the wild truck. In each of this work, we must equally commend USAID because we leverage on the COVID funding to procure 16 of these. Each one is being coupled with a portable digital X-ray and either a TB lamp or TrueNAT. This is just a mini wild truck, and it comes to a location, is stationed. And another good thing with the COVID that we've equally integrated COVID vaccination. A mobile team of COVID vaccinators accompany the work in a very hard-to-reach location. They are mounted there after the sensitization. They do the pre-diagnostic screening with the portable digital X-ray, and those that are presumptive, able to produce sputum, just right there, their sputum are collected, and there are the diagnostic evaluation done either using the TB lamp or TrueNAT. And right there, they will be able to be presented with their results, and we work in close collaboration with the local district TB team, or with those that are diagnosed actually linked on the spot. But another thing, I will still talk on the XMAP platform because there may equally be need for clinical diagnosis, or which through the XMAP, these results are uploaded to radiologists, even some of them outside the country. They will be able to read the result and send back to the radiographers across some of these hard-to-reach locations. And as I mentioned earlier, this had helped us to drive our COVID vaccination project. And not only COVID vaccination, we've been able to have an integrated health services that are being driven by the work, or which the community volunteers that accompany the work can actually screen the clients for both TB, for chronic diseases like hypertension and diabetes. And these things serve as an incentive to bring most of the community dwellers in those hotspot locations for integrated health services, not only tuberculosis. The next one. Now, learning from our experience, we've actually adapted a screening algorithm from the national program. As you could see in my left, every client in those hard-to-reach communities, we use the parallel algorithm. They are offered the WHO for symptom screening, and they equally pass through the CAD4 screening with AI using the portable digital X-ray or the wild truck, as the case may be. And you could see if you're presumptive and you're able to produce sputum, irrespective of your CAD4 score. We've set the CAD4 score for the portable digital X-ray at 50 and above, but irrespective of your CAD4 score, if you're able to produce sputum, we send you a sample for PCR, either GeneSpart, TB lamp, or TrueNAT. And depending on the outcome of the result, if it's positive, it is a diagnosed TB case and it's linked to treatment. But if it's negative, since the digital X-ray houses all the films, and we have already enlisted radiologists, those X-ray films are uploaded through the XMAP system directly to the radiologist. And these radiologists, I will talk more on the XMAP system. It had actually helped optimize our clinical diagnosis. But another pathway that if you are presumptive TB and you had no cough or sputum, but your CAD4 score is above 50, you are referred through the XMAP directly to the radiologist. But if you are non-presumptive based on WHO screening or the CAD4 score is less than 50, you will exist the cascade. Now, once we get result from the XMAP, is real-time reporting by these radiologists, and some of them are not even in country, but they receive these alerts either by email or text messages. And once they report, they send back to referring radiographer out there in the field. And depending on the outcome, if it's suggestive of TB, clinical diagnosis, and they are linked to TB. And another thing worthy of note that some of these radiologists are actually points to other pathologies, and the patients are referred as appropriate. The next. Now, this is the result. We try to showcase the result of our screening cascade, looking at the wild truck and the DLB, and this result depict our outcome for the FY22, starting from October 2021 to September 2022. Now, the wild truck is in my left and the DLB by my right. We have the two wild truck, the north and south. Before I go to the cascade, there's something here that is actually very, very clear. If you look at the number needed to screen to get one case through the wildcat case is 16 clients. And for the DLB is 44. I think if you do the stats, this may not be any statistical significance. And key to note is the number needed to test. You just need to test only 4 TB clients, presumptives, to get 1 TB case. And you will see that this is very, very highly efficient. And the same thing with the DLB. Using the WATROC for the FY or under review, we'll be able to screen 75,028 clients. And the presumptive identifier was 4,757, giving a 6% presumptive yield. And we're able to text almost all the cases, 4,752, and diagnose 1,105 TB patients, giving you a diagnostic rate of 23%, and treatment, or almost all of them were linked to treatment. This is on the WOW cascade. But for the DLB, using the ADLB, the 7 from the new tools project and 1 is the pilot DLB that we got on loan from there. We were able to screen 84,889 and giving a presumptive yield of 10% of 8,474. And we were able to test 8,464 and they diagnosed 1,928, a diagnostic yield of 23%, and 1,880 were commenced on treatment. Now, using this both the WOW, we could see we're able to get close to 3,000 TB cases within a given year of FY 2022. The next slide. Now, let me talk on the innovation. One good thing we work with a local IT company in Nigeria, because this is actually the beauty of a pilot project, or which we are known. In KNCV Nigeria, we've been able to introduce a whole lot of innovations in a TB program in Nigeria, and we must equally thank the national program. Not only doing the pilot, but what gladdens everyone's heart that you're able to come up with a pilot and you see it being taken to scale. I think that's the beauty. Now, we work with a local company because one of the challenges we noticed that you need to optimize clinical diagnosis. This DLB using the Hotspot analytics I'm going to show actually spread across very hard to reach locations. Some of these locations don't have internet connectivity, but you could remember that using AI is actually, I've seen my colleague's presentation from Uganda, and I did the calculation, it's about 62% clinical diagnosis, because you are reaching out and finding these TB cases at the early form. And most of them have not even developed cavitatory lesions, where you'll be talking about bacteriological diagnosis. But for optimize the use of this portable digital assay, we'll find it very useful in optimizing clinical diagnosis. We worked with IT companies, and they were able to come up with this SMAP system. Is an automated process for our digital X-ray reporting, drastic reduction in turnaround time for digital X-ray reporting, and optimize our clinical diagnosis. As of last week, when we were putting together this presentation, you could see it tracked every chest X-ray taken by all of the DLB. A total request of 7,551 had actually been captured across site and sent to the radiologists. But at the time of reporting, 7,510 had been reported and sent back to those radiographers. And I can key into my dashboard here. My field staff, the program staff can key and monitor the results coming from all the DLBs and the outcome. You could see by last week when I took the snapshot of this dashboard, you could see at that very day, 20 TB suggestive cases and 7 non-suggestive. And it takes it to the weekly report and monthly report. Very accurate in tracking our report and wider reach to all the DLBs in the field. And I must tell you, with some of the brain drain happening here, some of the radiologists that keyed into the SMAP system, some of them are even in Saudi Arabia, but that's still reporting through this SMAP, and we are getting the timely result. It's very seamless and very easy to use. But when we started seeing increased clinical diagnosis, one will wonder, are these false positive? And that's where we work with local IT team and introduced a system for quality assurance, of which I'm going to discuss in one of the program learning we shared with USID. The next slide. Now, this is one of the program learning. And now, when background to this, that would scale up of optimize the PDS with CAD4, we introduced the SMAP system under our project. Clinical diagnosis significantly increased with an improved TB notification rate, and it became expedient to institute a quality assurance system for clinical diagnosis. the SMAP with the local IT companies. It didn't have this, but seeing this result, we had to engage them to incorporate a system of clinical diagnosis. We went through literature, but I must tell you that even WHO are yet to come over and agree the system for clinical quality assurance for clinical X-ray. But from what we were able to design, we came up with two systems. One is reassigning randomly selected X-ray film for second reading and tracking the concordance rate. Presently on the SMAP, we have 7 radiologists, well-trained and well-recognized in the tertiary institutes, and the 2 of them actually outside the country. Now, what we do that we compare results between radiologists and try to track the concordance rate. And number 2, that's actually very key in this QA system, that we compare the concordance rate of selected bacteriological diagnosed cases with clinical diagnosed results. Because within the SMAP, we have all the X-ray films. We actually know those that actually follow the cascade and their GeneSpire result turn out as positive. For me and you, we know the sensitivity and sensitivity of GeneSpire. We provide those confirmed GeneSpire results and assign them to these radiologists to know whether, based on their knowledge, they will be able to actually confirm that these actually TB cases. And we, at the start, set our benchmark for 85%. But in the rounds of this QA we've been able to do, the concordance rate for the first method was 88%, and concordance rate for the second QA method was 79%. We'll see that majority of the radiologists actually, for those that are confirmed bacteriological or GeneSpire, actually confirm them clinical diagnosis. And one good thing in introducing this system, we kept these radiologists on their toes. They know that, no, not just that I'm reporting and being paid for the report, but somebody is out there keeping track of the quality. And very unfortunate, over 2 sessions of this quality assurance, we were able to pick one of the radiologists that couldn't meet our benchmark, and we discussed with him to drop from reporting the X-ray. But the key lesson that the concordance rate of 88% in the last QA that we did met our set benchmark in the round of QA, and the high concordance rate highlights the high reliability of the PDS facilitated clinical diagnosis, as well as the quality of reports that we are getting from these radiologists through the SMAP system. The next one. Now, another good thing, I told you earlier, the resources are limited. We won't be everywhere with only just 8 DLB and 2 wild truck. And one innovation we introduced under the TB loan is the Hotspot analytics. We are working with one partner, because LON is a consortium of partners that are actually helping us to do the Hotspot analytics. How does this thing work? In our TB surge we do within the facilities, patient data are actually generated down to the wards where these patients are coming. And it is actually triangulated under the EWAR alert system to generate alert based on the threshold we've already set. And our team reviewed this data on a weekly basis. And actually the outcome from this EWAR hotspot analytics is what informs where we deploy both the DLB, where we deploy the wild truck, and where we even do our community active case search, because you know the number of communities in even a given local government and the limited resources. And the EWAR hotspot analytics had made us very focused and targeted in our TB active case finding, and all which the number needed to test and number needed to screen will actually speak that to the fact that these are very highly profiled, targeted TB case finding intervention. The next slide. Now, very few, we classify this into technical equipment, program implementation, and operational. We've had some challenges, but I must tell you that we've been able to achieve what we've achieved because we learned during the pilot. And I must commend the Delft team. The issues we had with the solar panel, frequent unexplained breakdown, and some of these connectivity glitches. We've worked with Delft, and I'm happy to note that they've already appointed an in-country partner. Before, the Ghana team had to provide this support. Getting the equipment from Ghana had become issues, and it had actually led to a very long turnaround time. But having an in-country partner in less than 24, if you see the Mobison battery or solar panel that needed changes, it doesn't really obstruct interfere with our activities. But what had actually persisted is connectivity glitches, or which initially we had thought this is related to the laptop, or which some of the staff could use for other things, but they have been put on share mode. We are still working with Delft to continually improve on the connectivity. Now, for operational and program implementation challenges, in as much as we are finding the TB cases, I must say that this is actually cost intensive. For each DLB, we have a radiographer and an assistant, and these guys are actually very wonderful. They work day in, day out, and we could see the results. And you need to engage them. Most times in the locations they go are far from where they reside in town. There will be need for funding for them to stay out of location and equally improve, support their transport. And with the awareness on Keke, our plan now being rolled out that this awareness of Keke move a far location and station there to comb the communities before moving to another community. And this will come with logistics support too for transportation and for not all the DLB, because the awareness on Keke is being implemented in the states where we're implementing the COVAX, since the funding is coming from COVAX. And in as much as we get results, resources are actually needed to continue to scale up this intervention. The next, and finally, to say thank you from all of us at KNCV, I must appreciate Delft, the USAID, and the National TB Program, and most importantly, the patient out there and the state TB program that had partnered with us since the start of the TB Loan Project. Thank you.